Great. Welcome, everybody. Sorry for the delay. We've unfortunately had a couple of bookings where we're following on from a lecture, so we can't get into setup on time, but sorry about that. So anyway, we're going to give our special guest today the full hour. So if people need to head off early, then that's fine. But we're super grateful for Professor Dennis Velikoulis, a professor of neuropsychiatry from Melbourne, Australia, who's come today, not specially to give this talk, but he's in town, and we've got a fantastic talk lined up about, it sounds like Dennis has solved the gap between neurology and psychiatry. So a potential biomarker distinguishing neurological and psychiatric disease, neurofilament light. So we look forward to hearing about that. And rather than going through all Dennis's great accomplishments, and we're a bit late, so we'll crack on. But thank you so much, Dennis, for coming to talk to us today.
Thanks, Tim. Thanks for the invitation. Now, what happens with questions and things? They come up on the chat. End, yeah. Okay, great. Can I just minimise this?
Yeah.
Excellent. Well, thank you for the invitation at short notice. It's a pleasure to be here again. I've been here a couple of times over the years. In past times, very early days, my work was largely in schizophrenia imaging, which is where I cut my teeth in research. Now I've moved on, still doing schizophrenia imaging, but our work has moved on into our clinic and our patient groups, and trying to solve some of the problems that they bring up for us. So this is a typical clinical problem that I'm going to be talking about today. A 48-year-old man who had 4 years of cognitive concerns, 15 years of depression. He'd lost his job, he was depressed, he was drinking, he'd seen 3 psychiatrists, and then by the time the diagnosis of Alzheimer's disease was made, he was unemployed, separated, and his children no longer spoke to him. This is not, I've made this one up, but it's not an uncommon story about the fallout that occurs from diagnostic delays in the young onset dementia group. So I'll be talking about the clinical problem, which is the person who presents to you under 65, under 60 with cognitive concerns, and we're not sure if it's a psychiatric disorder, whether it's a mood disorder, anxiety, schizophrenia. Sometimes many people with long-standing schizophrenia will present with cognitive and functional decline. Or is it an undiagnosed neurodegenerative disorder? Statistically, of course, it's going to be the former, not the latter, but it's very, very important that we don't miss the latter. The diagnostic delay for young onset dementia is around 4 years. You could argue that's 3 years and 10 months too long. And there is significant personal, family and social fallout. So what if we had a biomarker? What if we had the equivalent of troponin for heart disease, or ESR, or CRP for inflammatory disease, to be able to help in that early stage say to ourselves, look, this isn't looking neurological or neurodegenerative, and we'll press on and do the needful from a psychiatric point of view. Or is the marker telling us that something's going on and we really need to investigate it? So just briefly about neurofilament light, it's a axonal protein that's released after axonal insult, any type of insult. It could be brain bleeds, it could be tumours, it could be stroke, it could be Creutzfeldt-Jakob disease. Anything that causes axonal damage will lead to the release of NFL into the CSF and into the blood. Been lots of work in the neurological field, particularly multiple sclerosis, where it's being used as a marker of treatment response. But there's also large literature in other areas, less so in psychiatry, but increasing. Oh, sorry, that relates to the video. So this is just clinical vignettes. These are true stories. So 2 people with almost identical histories of schizophrenia for 10 years, a couple of years of progressive personality and behavioural change, some behaviour which varies a little bit. One was a bit disinhibited, the other one was apathetic. A family history of Alzheimer's disease, some neurological signs in one patient but not the other, equivocal imaging, both on MRI and functional imaging. And then in the end, we're left to say, this could be a behavioural variant frontotemporal dementia, or it could be schizophrenia. It's a classic sort of conundrum in this area. So we're left and we think, we'll wait and see what happens. Time will tell. So we, as I'll go on to say later, these patients had come through our clinical unit over a period of time. They will routinely, if we suspect Alzheimer's disease, get cerebrospinal fluid done, or get lumbar puncture for Alzheimer's proteins. About 12 years ago, we decided we're going to keep all the CSF that we ever got in case something came up in the future and we could measure it. And that's what happened. So we, oops, wrong way. So moved forward several years because it's 10 years after we took the CSF and we were able to follow up what happened to the patient. So at follow-up, like 24 months later, Neil had improved. He'd been treated for schizophrenia and got better. His CSF neurofilament was normal at baseline when we'd originally done it. Jane, on the other hand, had progressively declined, ended up with a behavioural variant FTD and was in nursing home care. Her NFL at baseline was twice normal. So if we'd known that at the beginning, it may well have changed how much we investigated Jane, for example, and how closely we followed her up. So is it psychiatric or neurodegenerative is the very sort of bottom line of this talk. Now, NFL's not going to tell us if a patient has CJD, MND, et cetera, et cetera, et cetera. But what it can tell us potentially is whether it's psychiatric or neurological. So just a little bit about the unit. At the Royal Melbourne Hospital, we turned 50. This is just a bit of background to explain where all this has come from. We're a diagnostic service. We service the state of Victoria, about 6 million people. We're largely an assessment service. We have inpatients and outpatients. About 50% of our patients end up having a young onset dementia. This includes Huntington's disease, where we run Huntington's clinics, we run predictive clinics in Huntington's, but also other dementias. Those of you familiar, no doubt, with Lishman's Organic Psychiatry will know the sort of disorders in that book. We tend to see a disorder from every chapter almost every year. So it's a very rounded, very broad diagnostic group of people that we see. We also dabble in DBS for OCD. So we work across a number of areas and we have a strong clinical research focus and we work with community organisations as well. We also work, and this is important because for many years, for 20 years, we've worked with a lot of other parts of the hospital. Neurology, neurogenetics, metabolic disorders, neuroimaging, memory clinics, etc., psychiatry. As a result of these collaborations, we've been able to do the work that I'm going to talk about because doing this sort of work requires having good relationships with all the people you work with in a hospital. And that's why the list of people involved in this study is so long. So young onset dementia, it's a complex area. I'm sure it's the same the world over. Too young for age services, too complex for mental health services if they're presenting with psychiatric illness, and too difficult for medical services. So we have a multidisciplinary service, including neurologists, neuropsychologists, speech, OT, physio, nursing, etc., to try and diagnose and then provide some follow-up. So the clinical problem, referrals they don't come to you with a diagnosis of young onset dementia, they come to you with cognitive concerns, with personality change, behavioural change, and you're left with this question. Is there a diagnostic test that will help us in this distinction? Well, there is an example of this in terms of NMDA psychosis. So we couldn't look for NMDA antibodies 15 years ago, now we can, and we've been able to solve that question in that subgroup of people with a psychotic illness. So some of the diagnostic challenges, Alzheimer's disease and what we call pseudo-dementia, people who present with anxiety, mood change, etc. Schizophrenia, people who've had long-standing schizophrenia with decline. The differential diagnosis between frontotemporal dementia and schizophrenia is often a difficult one, particularly given that one of the commonest mutations to cause behavioural variant frontotemporal dementia, the C9orf mutation, will present with a psychotic illness in about 40% of people, often 2, 3, 4, 5 years before diagnosis. And 50% of people with young onset dementia will have behavioural or psychiatric presentations. So they come to mental health services. The impact on the patient, so this is just some of the work we've looked at and published. The diagnostic delay is up to 4 years. That delay was reduced to 3 years once we set up a young onset dementia service, but it's still 2 years and 10 months too long. Patients have seen an average of 5 specialists before they get a diagnosis. This includes neurologists, psychiatrists, physicians, geriatricians sometimes, and there's repeated investigations. So can NFL help? This is another vignette about a lady who was on the ward. I was involved in her care, depression, anxiety, some cognitive concerns. We thought this is anxiety, depression after a very thorough assessment. She had a little bit of, movements, a few movements around her lips, but there was no family history of Huntington's disease at all. So in retrospect, we should have taken that further, but we didn't. A year later, she came back and she now had a frank career, and she was diagnosed with Huntington's disease. NFL level of baseline, we would have seen that it was 3 times greater than the triggered us to go further down the or other. So the literature has suggested and shown that NFL is high in neurodegenerative disorders and normal in psychiatric disorders. So the literature is largely focused on individual disorders, NFL in Alzheimer's, FTD, NFL in MS. So we thought, well, let's take these observations and see if it can help us in this distinction. We're not interested in diagnostic specificity, we're just interested in whether it can cleave them apart. So the retrospective study I spoke to was part of a study we call Beyond, which involved collecting all of our clinical imaging and biomarker data in our unit since 2000. The CSF data dated back to 2010. So as I said, we stored the samples in case something ever came up. And obviously we did that with ethics. But so it was opportunistic. And then the ability to measure NFL came up. NFL has been measurable for many, many years. It's just that the kits, now the ELISA kits became available, became commercially available, and it was easy to do. So this was the original pilot study based on the first 100 or so patients that we'd seen. And so patients with psychiatric disorders, neurodegenerative disorders, and controlled subjects. You can see in orange there the CSF NFL values, and that in the neurodegenerative disorder they're in the sort of 3,500 range, and about 1,000 for the psychiatric patients and the controls. This is a box plot showing that there's pretty good separation of the populations, the neurodegenerative, the psychiatric, and the controls, and the psychiatric group. And this is a sort of a mishmash of diagnoses: depression, anxiety, schizophrenia. They're all bundled together. The neurodegenerative disorders are largely Alzheimer's and frontotemporal dementia. So this sort of was some early proof of principle that we could separate these two groups out. The area under the curve is pretty good at 0.94 in terms of separating out the two groups, high sensitivity and high specificity, in the order of the sort of values that you would like to see for such a test. And it performed better than tau and A-beta, which we're also able to measure. We followed that up with a much larger study last year, which incorporated samples from other groups that we worked with, and other diagnostic groups as well. So this study included over 200 patients with CJD. So it's biased towards the CJD group, but also 200 people with other neurodegenerative disorders like Alzheimer's disease and FTD, psychiatric people with psychiatric disorders and controls. Once again, very similar story. Not surprisingly, on the far left, the people with CJD had sky-high NFL levels. That's to be expected. Other people with neurodegenerative disorders similarly had high levels, and the controls in the mental health or the psychiatric group was below normal, which is that little red dotted line is the cutoff that we've been using. So once again, this tended to reinforce the idea that CSF NFL levels may be useful in this clinical distinction. Within this study, I've just opened it up to other diagnostic groups. You can see there's people with behavioural variant FTD, Alzheimer's disease, MCI, schizophrenia, bipolar disorder, major depression. So that the normal NFL in the patients with psychiatric disorders seems to hold steady across all the psychiatric groups, and the higher NFL seems to work across the neurodegenerative groups. We replicated the original performance of the study in the pilot study in terms of area under the curve, sensitivity and specificity. So this was a larger follow-up to that early CSF study. So we then went back, again, because this was a retrospective study, and said, what if NFL levels were available to us at the baseline assessment of our patients? Not all of those hundreds of CJD patients, just the patients we had seen in our clinic. So one of our registrars went back, found, well, nearly 200 patients that we'd seen and tracked down what had happened to all of them. And so within that group, there are about 120 who'd been finally diagnosed with a neurodegenerative disorder and 70 or so who'd been finally diagnosed with a psychiatric disorder. So we looked at their NFL levels at the baseline assessment. You can see that the neurodegenerative group had a higher NFL level than the psychiatric group, who were a bit lower than the MCI group. Again, not unexpected. This complex sort of map tells you what happened to the patient. So the initial diagnosis is in the middle. So 134 were initially diagnosed with a neurodegenerative disorder. Some of them made, after many years of follow-up, made their way into the psychiatric group. Some of the psychiatric group made their way into the neurodegenerative group in terms of the final diagnosis. So when we just use the final diagnosis as the gold standard, the baseline NFL predicted that the final diagnosis, in some cases, better than the original clinical assessment. So that in the neurodegenerative group, predicted the diagnosis in 93% of patients compared to 89% as predicted by the baseline clinical assessment. So it seemed to work quite well in the neurodegenerative group and probably a bit better in the psychiatric group as well in terms of predicting at baseline this person has a normal NFL, it's not neurodegenerative, and it ended up being psychiatric. So based on these studies, I think it was fair from our point of view to say that high NFL is a red flag. A normal NFL probably doesn't exclude a neurological disorder, but a high NFL should prick your ears and make you think something's going on and I better investigate it further. We then moved into a blood study. CSF is not that easy to get, and blood is obviously much easier and more acceptable to patients. So this larger study, the MIND study, now is looking at much bigger populations of patients with collaborating with many other groups to try and get as many blood samples as we can from as diverse a group of patients as possible. It's funded in a couple of ways. This is just an outline of what the study is. It's a 24-month follow-up study. We get baseline NFLs, follow people up for 24 months. We've had over 1,000 referrals and analysed 400 samples. I'm going to show you just a little bit of the data from the early blood work in a sec, not yet. So, no, I am actually. So I'm going to now talk about some of the subgroups, some of the clinical conundrums that we have. So treatment-resistant schizophrenia. So I work with Chris Pantelis and Ian Everall, who set up a blood-brain imaging bank for people with treatment-resistant schizophrenia, and looked at their neurofilament light chain. You'll remember that the schizophrenia people in the earlier study, which were not from this bank, in green there had normal NFL levels. That's what we found in a treatment-resistant group. So this is people with 10, 15, 20 years of illness. It was a little bit disappointing. We sort of hoped that the treatment resistance group, not hoped, but we thought they may have had higher levels. Some of us have sort of thought along the way that some people with schizophrenia may have a neurodegenerative disorder as opposed to a neurodevelopmental disorder. But the data here suggests that their NFL levels are completely normal. So that's not a bad thing in a clinical context. Someone with long history of schizophrenia presents with functional or cognitive decline. You're wondering what's going on. Is it a medical issue? Is it the medication? Is it substance use, etc., etc.? A normal NFL reassures you that it's probably not going to be neurodegenerative. There's a syndrome related to frontotemporal dementia. People may not be familiar with it. It's called the phenocopy syndrome. So these are people who present, for all intents and purposes, as though they have frontotemporal dementia clinically, cognitively and imaging, but they do not progress. They don't progress over time. And this has been termed the phenocopy syndrome. John Hodges from Melbourne and the UK was instrumental in sort of identifying this syndrome. What we showed in this study was that NFL could help us predict who would go on to progress and who didn't in this group. So again, this is a clinical scenario that we're faced with all the time, where NFL could be potentially of value. Those of you who work in the epilepsy field will know about the difficulties with diagnosing psychogenic non-epileptic seizures and epilepsy, and you need telemetry units, etc., and you need to have long-term EEG and video EEG and capture seizures. So we thought, wouldn't it be great if NFL could just help us distinguish? Well, it doesn't. So NFL was normal across all the epilepsy groups. More recent data, though, showing us that people in status actually have pretty high elevations of NFL. But these are people not in status epilepticus. These are people who are having normal epilepsy. So it's not helpful in this context. So moving on to some of the larger blood, the 400 or so that we've looked at so far. On the left are the neurodegenerative disorders, Alzheimer's, behavioural variant, and others. And then on the right are all the psychiatric disorders, schizophrenia, bipolar, depression, etc., and controls. And again, we're seeing the same sort of differentiation. High NFL in the neurodegenerative groups and low NFL in the clinical groups, with sensitivity and specificity that would be pretty acceptable in clinical practice. Area under the curve of 0.95, which is pretty good. Sensitivity and specificity in the high 80s. So, where are we going next? I'm going to finish early without that video. Where to next? So, how do you get a test like this into clinical practice? So, you can do the sort of work we're doing and other people around the world are doing to see how NFL behaves across different clinical populations, and you have to sort of try and measure it in as many clinical populations as you can, which is what we're aiming to do. We now have a grant to look at it in a much bigger group of mood disorders and anxiety disorders. You also need to understand, if you're going to bring a test into clinical practice, how it behaves in non-brain diseases. So is it raised in renal disease? Is it raised in liver disease? We have some studies that suggest that it's probably not, but you need to do that work in large groups of people with thyroid disease or any other medical condition, just to make sure that NFL is not raised in these conditions. The impact of age. NFL is probably not as good in the over 65s because it goes up with age. So the sensitivity and specificity actually drop off in the over 65s. In our group, of course, under 60, it performs much better. There's probably an influence of BMI as well on NFL. We're still trying to work out exactly what that is. And then finally, the tests I've been talking about, the assays are all in a research setting. You actually have to buy a fancy machine from Quanterix or Roche, which costs several $100,000. Then you have to buy their kits, and it's like printers. You buy the printer, and then you've got to keep buying all the dyes. So if it's going to come into clinical practice, it has to be a test that you can do in your normal hospital pathology department. Unless you're really wealthy and you've got people who can man the machines and you buy lots of them. In Sweden, they've actually got banks of what are called Samoa machines to do this. But that's not practical for other countries. So we've been working on this with a group of my collaborators at the Walter and Eliza Hall Institute. They're not a brain institute, cancer, infectious diseases, etc., but they've gotten interested in this area and looking to develop something called, don't ask me the details of this, proximity ligation assay, which is a combination of, so you attach monoclonal antibodies to the neurofilament, then you use polymerase chain reaction to amplify the signal. And this then allows you a very cheap and so far pretty effective way of measuring neurofilament. The beauty of this is that it may well be translatable to any other protein you can think of in the blood, this particular assay methodology. So what's the current technology worth? Well, currently, and I've converted it to pounds for your benefit, the Simoa machine, it's about £84 per sample. Not cheap. If we or others, doesn't really matter who, as long as it happens, can develop an assay that is used in a general hospital pathology lab, it'll come in well under £5. So that's the difference between, you know, the commercial measurers of NFL and trying to develop a technique or an assay that you can do in your local lab with the equipment you already have in the lab. This is some of the early work from the WEHI assay, and what we've been able to do with the Royal Melbourne is collect samples of blood from people who've had other medical diseases, and they're paired. So you can see in the red rectangle there's a pair. They're two samples in the same patient. But what's interesting here is people with cardiac arrest, intracranial hemorrhage, congestive cardiac failure, cardiac arrest again here on the right, do show elevations in NFL. So that's probably a brain thing. Can't completely exclude it's a cardiac thing, but this is very early data, but it gets back to the issue I was raising before, that we need to test it across as many medical conditions as possible to know how it behaves. So just finally, how much would you be willing to pay for a test like this? We actually ask all our participants, what would you be willing to pay for a test that would do this? Okay, so the current cost on the left, £84. People with symptoms were willing to pay £319 for a test like this. People, control subjects were willing to pay, thought it would be worth £450. So I was a bit surprised by this, but I'm not sure what people in the audience would be willing to pay, but it's certainly more than what it costs now, and certainly a lot more than it would be if we could get it into the general labs. So this is a link, but it's not going to work. I don't think it's going to work, but it's a link to an app that Dharma, who works with me, has developed with Kai Bleno and Henry Zetterberg, who are sort of the pioneers in this. Sorry? Oh, it does work. Oh no, it does work. Am I continuing? Okay. Oh. Excellent. Okay. So. I don't know if the people online can see that or not, because we might share that. Okay. Well, I've got a screen grab of this anyway. Let me go back. I've done a screen grab. Oh no, I didn't. That was in the old version. Okay, so what we've done, Henry and Kai have kindly allowed us to borrow 2,000 of their controls and their NFL levels, and Dharma's been able to put together this app, if you like, that potentially, you know, we might be able to use in the future. And what you can see here are centiles and mean of NFL levels across the ages. So you can pop in whether it's serum or blood, the NFL level, let's call it 12 for a 60-year-old, and you can see where it lies on the spectrum of normal or abnormal. So if you go up to 35, it'll, you know, this person will jump up into the sort of the 97th centile. So it's not dissimilar to the way we read hemoglobins and any other urea electrolytes, etc. So, but because age sort of changes the levels, this sort of app is going to be much more useful than just the number. And you can access this app and play with it at your heart's desire. So is the future closer? So what we're trying to see is if NFL can help us in the early stages, pre-symptomatically, maybe at first symptoms, to identify that something neurodegenerative is going on. So it's potentially a biomarker which can help us rule out neurodegenerative disorders. As I said, it's non-specific and non-diagnostic, but that's probably one of the strengths of it. Clinical reintroduction relies on much further validation and assays that are cheaper and more readily available. So that maybe one day you can do this, or the GP can write a form and ask for an NFL. That's just, we have an online REDCap method to collect referrals. So I've already talked about all these people, particularly Dr. Dharmaduraran, who's doing his PhD in this area, is instrumental in all this work, but a host of other people. Thanks.
Thank you, Dennis. Amazing work, considering we stress tested you by getting your video. We put you in a cold room off the back of a flight from the Australian summer, hence the coat still on. So we couldn't have put you through a more stressful experience, I think, but amazing.
I've survived.
Yeah, thank you so much. So really fascinating and really interesting, and great to see clinically relevant, potentially really meaningful work there. So I've got a few questions as well, but in the meantime, I think we've got a couple of questions in the chat and online, but maybe David, okay, so you've got your hand up. Do you want to, if you can unmute and show you, and then, say hi to David. I think you're,
Stop sharing.
Hang on, I can do that whilst you chat. So David, do you want to fire ahead with your question?
I think it was first, actually. I'll let him go first, just because the etiquette of Teams meetings.
Sorry, did you say that I should go first, David?
Please, Nick.
Yeah. Okay. Okay. Thanks. Hi, Dennis. Very nice to see you again. And thanks for a great talk. A couple of questions, actually. The first one is there's an ongoing debate in the literature about whether schizophrenia is in itself, chronic schizophrenia anyway, is in itself a neurodegenerative condition of sorts. I guess, obviously your work isn't set up to answer that specific question, but it appears like it might be answering it, in that if it is a neurodegenerative condition in some sense, it doesn't seem to be degenerative in the same way that all these other diagnoses are. So I'd be interested in your thoughts about that. I suppose my other question is, obviously the data as you presented it looks very convincing in terms of being able to differentiate different types of disorders, but I suppose it does rest on there ultimately being a diagnosis of a neurological or a psychiatric condition. As you've said, that diagnosis is difficult. So is there some kind of rubric you apply to the robustness of those diagnoses to feel confident about that final diagnosis and which category the patients end up in?
Thanks, Nick. So the first question, so as I mentioned earlier, my early career and ongoing career is looking at schizophrenia and brain imaging, and with Chris Pantelis many years ago, we would scan first episode patients, and we published a nice study suggesting that there was possibly, during the transition from high risk to first episode, some structural change over time, and which led us to think, could this reflect a neurodegenerative process? And that's been replicated since. Now, if we were to do this study, and we're trying to, but it's pretty hard to do, ideally to answer your question, is take people at high risk, measure their NfLs, and then when they develop a psychotic illness, once again, measure their NFL and see if there's any change over that period or in the first 4 or 5 years, when we think that's probably the time when there's going to be some structural change. After that, the sense is it probably plateaus out. So maybe we're just measuring NFL at the wrong time in people with chronic schizophrenia. There has been some first episode work done, and the levels are actually normal in first episode psychosis. With the second question, look, there is no rubric, if you like. The diagnoses that from our group at least are all based on our clinical assessments. They're not all having structured interviews and things, but it's gold standard, state of the art imaging, LPs, neuropsychology, etc., to come up with a diagnosis. The groups that we work with, many of them like Chris's group with Ian Everall, the treatment-resistant schizophrenia group, is a very well-defined group. That's a research study that's been undertaken. So the patients are very well-defined in terms of their diagnoses. Similarly with the bipolar group that we're working with, Michael Burke in Melbourne, they're very well-defined patients. Some of the CJD patients are clearly, they're diagnosed based on 1433 levels, etc. So we don't have many post-mortem diagnoses, though, in the neurodegenerative disorders. So yeah, that ultimately is the gold standard. We do have, in the Alzheimer's patients, though, CSF, A-beta and tau, which we know correlates pretty well with amyloid load in the brain. So in some, yes, we do have, the gold standard diagnosis. In others, probably not as well.
Yeah, no, that's great. Thanks very much.
Well, hi, Dennis. We haven't met, and I think we're scheduled to meet tomorrow. Thanks for that talk. Really fascinating. I had an observation, and then I had a question that was three-part. So the first bit was the tests are interesting because actually what you learn from a clinical perspective is it's not the tests that are the issue, it's the service and infrastructure around the tests in order to add a meaning to the tests. That is the challenge. Specifically, especially when it's a test that has this physical interface neuropsychiatric component to it, because then you almost need an advisory service to get to act on the implications of the test. Because I think it was interesting to see your data. What it suggested was that the confidence intervals were quite wide for. Sorry, is there a weird echo? Is that me? Yeah. So the confidence intervals were quite wide, which might mean that there's a really strange echo. Sorry. Actually, the overlap of those confidence intervals is needless to give a clinical interpretation to the meaning of the test results.
Or do you want to recap?
Thanks, David. I heard that there was a fantastic talk. Thank you. Yeah. Look, no, there overlap. There certainly is overlap, but I think, when we look at the sensitivity, specificity area of the curve, the numbers there are telling us that it's pretty good for what we're seeking to do. Look, and the other thing we're doing is, again, if you're going to start interpreting a new test, you have to get experience with it. So we actually have regular sessions now where we present a case and then people have to guess what the NFL might be. And then we learn from that in a sort of recursive way. And we've been doing that for quite a long, and it's quite entertaining.
Brilliant.
The second part of the question was, do you know how it works in by way of sensitivity in alcohol, NMDA or LGO1? And also active MS versus sort of more nascent MS.
We don't have much data in alcohol. We personally don't. We're trying to get it because I'm not sure what came after alcohol.
NMDA and LGO1 for two.
So there's some pretty good literature in NMDA now. We're working with some groups in Melbourne to do it in the in MDA as well, but there's some pretty good literature looking at its potential utility in MDA psychosis, so that if the NFL is normal, then you're probably not going to have an NMDA psychosis.
Brilliant. There's a linked question that I was going to ask, but I think Joe in brackets guessed, I don't know if you're able to ask the question, but it was one on my mind about you seemingly have shown, well, at least a test that's almost as good, or at least almost, it seems almost better, in presumably because you just were better powered for your study. But it seems like CSF doesn't add a huge amount. Is that correct? Or does it still add something in the sense that you might go on to do a CSF NFL? But I don't know if, Joe, you had any other points to add around that.
The correlation between CSF and NFL is sort of consistently being shown, and plasma has been consistently shown to correlate very highly.
Okay.
which it's a really important question.
Yeah.
But there have been a number of studies now showing, and including in our group, that blood and CSF correlate very well. Why would you still need CSF? You still need CSF to do all the other CSF things and to look for Alzheimer's proteins, but
If you come around here, you come around here, Katie, and then you can see yourself.
Hello, everyone.
We're on mute.
With okay, so in terms of the so the CSF and the blood are quite similar, you were saying. Has it been tested in those cardiac groups? You know, where you said there's a raise. No, because I wondered if that would be interesting to see.
It would be interesting,
you know,
but trying to get CSF on someone who's had a heart attack
it's quite
might be tricky. No, it hasn't yet. No.
Naruj got his hand up. Please, John.
Hi, Dennis. Hi, good to see you. Thanks. It's exciting talk. I had a couple of questions. One was in relation to acute versus chronicity. So you've clearly shown early neurodegenerative disorders like, say, MCI. But how early do you reckon some of these NFL changes might be present? So that's one. And secondly, you very early on mentioned, I don't know whether I missed the data on brain injury. You seem to mention very early on about brain injury. You're mute somehow, Tim.
Probably Hannah trying to be helpful, muting us whilst you're talking. So sorry.
No, I mentioned brain injury very early on, only in the context of areas in which NFL is being looked at. We're not actually looking at any brain injury patients ourselves in this study. The brain injury literature, though, has looked at quite a lot of markers like NFL, but also S100 and NSC, etc. What we know from those studies and other work is that NFL, after an acute insult, takes a little while to peak. It's not as quick as some of the others, and then reduces over several weeks. That's in acute brain injury. I suppose in neurodegenerative disorders, presumably there's ongoing brain insult, so you're going to maintain the levels of NFL. How early? It's a really good question. I think we're trying to answer that question and understand it, and the field is trying to understand it. My response to that is sort of not quite a scientific one. It's more that I think the NFL goes up well before the 4 years that it takes us to diagnose these conditions. So, yeah, I don't know the answer to that.
I mean, that even brings you into the realm of screening, doesn't it? I mean, thinking about, especially if you've got a family history. And,
that's right, yeah.
Thank you.
Great. So I'm trying to toggle between the questions. But in the meantime, Ishak Awatli mentioned a similar question about timing of the samples. So I guess the other issue was, with you mentioned interestingly about status epilepticus, and I guess it's interesting to look at can you distinguish functional seizures from, but I presume you'd need to look at some functional status patients to confirm. I mean, you wouldn't imagine it would be, but it'd be good to confirm that. But again, similarly, do you know how long that would last? It would still be perhaps a useful test, given the fact we know that the misdiagnosis rates.
Well, if the status finishes, I'd imagine it's like a brain injury. It takes a couple of weeks. It's an important question in some respects as well, though, because many of the people who are in ICU with status don't have status epilepticus; they have functional status. So maybe a helpful distinction in that, helpful biomarker in that group. Not aware of any studies that have been done.
Yeah, it'd almost be a clue the other way around to start looking for a functional diagnosis if it's normal, perhaps. Great. So just trying to see if anyone else has got in the room got any questions, or I'll go through to the people. But otherwise, I think it's really, next steps, is fascinating. In terms of when are you going to put some data? I mean, is this a world first for the data, or have you presented it elsewhere?
Oh, we presented it, we published it.
But the latest stuff, that first go of the plasma
that's
samples?
just gone in.
Oh, it's under
gone in, yeah.
It's under review, but not a preprint?
No.
Not okay,
yet,
yeah. So this is quite new.
It is new. Look, I mean, the NFL is exploding the literature.
Yeah.
I mean, we've got a different graph showing the number of publications. So, look, it's novel in the terms of the question we're asking. Most people are asking, is NFL raised in MS? Is NFL raised in FTD? So it's novel in that respect. But there are many groups now looking at NFL and schizophrenia. It's only helpful to us in that sense, in terms of getting a test out, because the more data that shows that it's normal in these groups and abnormal neurodegenerative groups, the better.
Yeah. Fantastic. So there's one more hand up that's come up from Ilias, if you wanted to unmute and ask your question.
Yeah, hi. Yeah. I'm not sure if my question was answered when I put it on the chat, when you were muted. I was wondering if NFL has been measured in people with autism. Oh, sorry, I cannot hear you. You're muted again.
I don't know off the top of my head. I can't tell you. Probably, but
okay, no problem. Thank you.
Yeah, it's an interesting question. Okay, any final hands up or questions? If not, a couple of shout outs for a few things. The first one is that the Global Neuropsychiatry Group, Jazz Singh in Australia has set this up. So if you're a trainee or a professional in neuropsychiatry related areas, not just a neuropsychiatrist, then I'll put the links in the chat after this. So do get in touch to join this group. The British Neuropsychiatry Association meeting is this week. It's just £30 for both days for students and people from low and middle income countries to join. So do join us. And just to quickly mention our next meeting, which is on the 14th of March, which is Chris Wincup, which is an update on the neuropsychiatry of lupus. Be a great and sort of interesting topic as well at the sort of boundary of psychiatry and general medicine. So once again, thank you, Dennis, for a fantastic talk, and we look forward to seeing your paper in Nature coming out soon. So, yeah. Thanks again.